I will step in and take over while Eunice is sorting out some technical challenges, and want to thank both of you for superb presentation. Excellent. He may be coming now. He may be coming now, and I'll step back as soon as you're on, Eunice. But in the meantime, maybe Francois, you can start off. Can you talk a little bit about adherence challenges? I was really struck by the fact that you're not seeing PrEP breakthroughs. I mean, that's really superb. But, you know, are we really getting to the big issue of adherence to prevention?
Well, I think the big news, I really do think this cabotegravir breakthrough is a major breakthrough. It does suggest injectables are going to have a major role. And, you know, in the tenofovir Taff studies, there are so few infections in the tightly controlled studies that the only reason I think that cabotegravir is working that well is because it's just the adherence is that much easier. So I'm tremendous. I've always been a bit of a PrEP skeptic, as you well know, Kate, from the ancient days, from when first IPREX came out and all of these studies. I really thought, well, this is going to be great for like a handful of gay men in San Francisco. But this, honestly, I think for women everywhere is really terribly exciting. You know, the PrEP has transformed prevention in richer countries, and here we are being offered something that has the ability to deal with our biggest impediment, which is not toxicity, it's just adherence. So yeah, I'm very excited.
So, and I guess, Kogie, the same kind of question. I mean, are we moving towards increased adherence with the new products that are coming down the line now? And how available are injectables, for example, in sub-Saharan Africa?
To answer your first question, Kate, so I mean, these long-acting injectables were designed with adherence in mind. It was designed to help people with a chronic condition not have a daily reminder of their chronic condition, and being by daily pill taking. And in actual fact, you know, with these long-acting injectables where you require an injection perhaps once a month or once every 2 months, you know, it's a huge step forward to sort out adherence issues. The challenge, of course, is that we don't see the drugs coming to Africa anytime soon. We follow the WHO guidelines in the public sector with respect to provision of ART, and it's pretty much oral regimen currently and in the foreseeable future. I do think that we still have more work to do to get the injectables into our setting, work around how to introduce it into our setting, and how to get it into our clinics. I think the big issue is that a lot of the trials that have been published don't actually go into the detail about how patients with pre-existing adherence challenges, when they then switch to an injectable, how well or poorly they actually perform. Very often the patients in these clinical trials are hand-selected, they're ART naive, they're not treatment experienced, they're not, or if they are, they haven't failed a previous regimen for non-adherence. So in a real world setting, looking at whether the long-acting injectable actually becomes a solution for people with adherence challenge, especially the long-acting antiretrovirals, we still don't have data for that yet. So there's a few ways of looking at it, actually.
Okay, so here's another innovation I'm going to ask about. This is Chisamiso Mudanyanga, who's asking, I'll throw this at you, Francois. They're piloting point-of-care viral load testing, and they've seen many clinicians having trouble, following up with viral load results, getting a hold of patients, and so on. Is this being done in certain settings? How common is this? Is it being rolled out?
We've been promised this for a decade, and it's the only point of care that's important. It'll transform HIV programs. There's been such a focus on point of care CD4 counts for reasons that are a little bit beyond me, because at the time that they were being rolled out, there's very rare situations where you need a CD4 count to make a decision, particularly in the test and treat era. Point of care viral load in my clinic, where I used to work, it took an average of 14 months for people to switch regimens, and part of that was just people lost the viral loads; they just didn't follow them up. And even in well-run clinics, it takes 3 to 6 months. So this really would be a major step forward. So, you know, in large clinics, if you could the patient could walk in and have a point of care viral load, it's undetectable, they have no symptoms, they probably never need to see a healthcare practitioner. They can just continue on their drugs. So I'm very excited at the work that you're doing there.
Okay, a question now for you, Kogie, and this is coming from one of our local committee members from Namibia, Flavia Mugala Mukungu, and that is TDF-based treatment is associated with bone mineral toxicity, as we all know, and the resources to diagnose osteoporosis are limited in low-resource settings. So how can we handle what she's calling a hidden epidemic?
Sure, and look, this is a problem. We haven't yet quantified the extent of the problem. Certainly, with us now using tenofovir in our first-line regimen now for several years, we don't know enough about who's at risk. Is the risk the same across all ages? Does it get worse with duration on therapy? What are the low-cost alternatives for monitoring bone mineral density loss? What is the clinical approach and who should get referred? Have we actually seen increase in fractures in our patients on chronic antiretrovirals? So surely that would be the end of this progressive leaching of the bone. So I think that, yes, it could be a hidden epidemic, but I don't think we know enough about it. And what I would urge is clinicians on the front line to do some implementation research, start keeping records and publishing your data on how much of a problem this is in your setting and who's being affected and to what extent are we seeing fractures in our patients or other clinical manifestations of this decreased bone mineral density. So, we're calling it perhaps a silent epidemic. Is that true? And let's understand this better so that we can find innovative solutions to addressing it. But of course, we've got Francois here, so I'd like to get his comment as well because he's got first-hand experience with doing this and using.
And maybe he can also answer at the same time this question from Cesar Magumba, basically saying, well, Taff seems to be a better option, though not completely clean, and he's concerned about how readily available Taff is in sub-Saharan Africa.
The Taff is being rolled out in Botswana and Zambia in pilot projects. In fact, it's going into the major guidelines. As I said, we're unclear as to its role in the obesity aspect, is whether tenofovir is mitigating that. I agree completely with Kogie with what you said about. So what we have on the one hand with Taff is DEXA specified impact on bone density. There's no debate that Taff seems to have less impact than tenofovir, particularly with spine and hip. We also have no debate about Taff seems to have less of an impact on the tubules than tenofovir, but we have no clinical data to correlate with that. There are some studies which may suggest increased fracture risk with tenofovir, but those again are done largely on white patients, and fracture risk amongst black patients is very different in Africa versus, say, North America and Europe. There's all sorts of theories around that related to weight and to vitamin D levels and goodness knows what. So you kind of, on the one hand, you've got a laboratory-based thing and with Taff, on the other hand, you've got the situation where there's this weight signal that's come out, which I actually don't think is Taff. I think tenofovir mitigates that. But until we've worked it out, it's difficult to say to go across. The benefits of Taff are we may be able to get rid of creatinine monitoring, and it's cheaper to make at volume, it seems, than tenofovir. Hi, Eunice.
I finally sorted out my technical woes.
Great to have you, Eunice.
Thank you very much for an excellent presentation, although I spent most of the time trying to undo all the technical issues. So
Eunice, do you have questions? Turn over to you now as the chair. So do you have questions?
Well, actually, I had tons of questions, but I don't know if you'll have addressed them or not. One of the most impressive things that I took from Kogie was that we are trying to get things done in real time. because we have realized that systems and processes that rely on information coming to the clinic at a later time is just too difficult to deal with the numbers that we have. And then getting patients in to do what's right for them at that point becomes a challenge. So if you have all your information at your hands, at tips of your fingers, when the patient is right in front of you, you can start implementing things. And the patient also realizes how important it is, whatever you need to do, and therefore takes you very seriously. Kogie, would you say that's more or less how you see what has been, how things have evolved in the field?
Absolutely, Yunus. It's just that also the field is taking giant leaps ahead of us. You know, we're going off in different directions with non-tenofovir based therapy when we're just wrapping our heads around the tenofovir in our regimen, and different types of agents that's in the field. But the questions coming through on the chat highlight the need for clinical vigilance. And the need for data coming out of Africa to see whether the issues that may be theoretical or may apply to populations outside of Africa are relevant here. So
absolutely. So the other thing that impressed me is that we are going on to injectables, which comes with a whole host of challenges. And I wanted you guys to wrap your minds around some of that. You know, one thing is that the doctor is accustomed to writing a script, handing out the script to the patient goes and collects the treatment, and you pray and hope that they swallow their tablet. How do you see the injectables fitting into that process? Because you must remember, now you write the script, that injection needs to be delivered by the healthcare system before the patient leaves. And our system is not quite designed to do something like that. So what systems and processes you see will need to change to accommodate for that? Francois, please feel free to enter the discussion. What do you think?
Yeah, I mean, Kogie, maybe you should answer, because I think I gave some of that earlier. It's a nightmare.
So the key issues, of course, is in high volume facilities, the number one is injection safety. You know, how do we administer injections to patients? How do we maintain safety amongst healthcare workers to ensure that we keep our staff in the field seeing patients? How do we address and redesign our programs to accommodate for slightly longer visits but less frequent visits? So at the visit where a patient comes in, how do we reduce bottlenecks at the point of where the patient is getting the injection? How do we introduce task shifting? Like the way we did very successfully when we had injectables in the drug-resistant TB regimen, you know, where you have injection teams and working around where patients are rather than having patients come to the health facility. So I do think it requires innovative redesign, innovative thinking around how we process huge numbers of patients coming to health facilities. The big issue, of course, is cold chain. Some drugs require a cold chain requirement, and in many of our settings, not even in resource limited settings, even in the resourced settings, maintaining cold chain is a real challenge. And so how do we actually practically do it to maintain the fidelity of these products? So I'll allow Francois to also give some of his comments, should he have any.
No, I agree with all of that. I think it's important. I see there was a question also about cardiovascular events with Taff. There was a small study at Croy, but very short-term studies. Showing maybe an increased risk of cardiovascular risk with Taff. It's too short a time, too little data to actually. So before we start getting scared, I would just wait for that signal. Just on the fracture risk, we had 3 fractures on Advance on the big study we did. One was tasered by their boss, one was hit by a truck, and one was running away from either being the muggy or the mugger. I'm not quite sure which one it was, but it was very much welcome to Joburg. So I really hand on heart can't blame the tenofovir for those fractures at this stage. So we really do, like Kogie said, like, please get your data out there. If you've got a decent number of cases, publish them as quickly as possible.
Another issue, and thanks, Kogie. I mean, you answered my question with a whole series of questions, which means we're having a great discussion here. Because clearly we are entering a new paradigm, and entering a new paradigm comes with a whole lot of questions. You know, the other thing that concerns me is we have huge problems with stockouts. And my fear is that if people are on injectables and if they come in, you can't very well say come in tomorrow, come in the next day. So we need a lot of wiggle room in the time frames within which injections need to be given. How do you see us dealing? And Francois, I know you with the Clinician Society often have to write out advisories on how to deal with stockouts. How do you see something like this happening with injectables, and how would we deal with it? You're thinking very hard.
So I'm not sure whether you're addressing me or Francois.
No,
Yunus,
I was asking Francois, but as being the only. Go ahead.
Yeah.
Go ahead.
So we have data that shows extremely long half-lives in many of these injectables. And you had latte and then you had latte 2. One was monthly and the other was 2 monthly. Then you have the islatravir studies that looked at varying doses, and they found that the lowest dose was actually just as effective as at the higher dose thresholds. So I think we're dealing with these really amazing compounds that have a long half-life, that are sustained, and I think we need data to understand what that actual window period is in which we can allow delays in giving drugs. I don't think that data is out. Most of the data has come from randomized trials under very controlled condition, good retention effort, good participants. In terms of how forgiving these drugs are with delayed dosing, missed dosing, I don't think we have enough data. We simply don't have enough experience to answer that accurately.
No, I get you completely. Francois, what do you think? I mean, do you think?
I think Kogie's summarized it beautifully. I think there's lots of thinking to be thought, for us to get our heads around what healthcare delivery system is going to be required for these drugs. And I'm just really excited about these new wave of injectables, not just cabotegravir and rilpivirine, but all the others as well. And Kogie mentioned these islatravir and these others. I just think we're at the precipice of a new form of delivery of care that is going to take away at least one of the headaches from us, but it's probably going to give us a whole lot of extra ones.
Yeah. No doubt about that. But the one thing I always turn back to is that if I had to tell you now that there is a disease that will require 4 to 5 injections a day to keep you alive and well, you would say it would never happen. And yet we do that with diabetes. If we manage to treat a disease like that with injectables, there is no reason whatsoever why we cannot step into the injectable field in HIV. So I'm very optimistic about all of this here, although I understand that it's giving us a lot of things to think about. So really going from randomized controlled studies where things are very rigorously controlled to programmatic situations is going to be a huge leap when it comes to injectables. Clearly, we're going to need demonstration studies. We're going to need real life studies to address much of the questions that have come up in this conversation. What do you guys think?
Agree completely.
Absolutely. Agree completely, Yunus.
Yeah.
And in our own populations, I think that's really important. We don't want to be caught with our pants down like we saw with the weight signals, where it becomes apparent, in black women later on in the game. So we really just need our own data. And what you said earlier, publish your case series because we can see it here first.
Absolutely. I'm not sure how we're doing for time. I've actually, all my excitement dealing with all of this here, I think it's close to out of time. Do you guys have any idea of how much of time we have left?
No, we're done. We've got a whole of urgent messages in the chat telling us to shut up.
Okay, there you go. So all it remains to say that thank you very much for bearing with me with all the technical issues. I quite enjoyed your presentations and I look forward to engaging again in the future on this. And we thank Janssen for hosting this symposium. Thank you very much.
Thank you. Thank you, Janssen. Thank you. Bye-bye.
Bye-bye.